last but not least, we've got Erin coming to talk to us. Erin is a dietitian that works at the Peter MacCallum Cancer Centre in Melbourne, and she manages the care of patients attending the multidisciplinary neuroendocrine clinic there. She's got a wealth of experience, and as I said just before, she is currently working on her PhD with a special interest or focus on neuroendocrine patients. And I know from patients that that are here in the room and that I've met at Auckland Hospital who've been across to Peter Mac that they all think very highly of Erin, and I'm really pleased to meet her myself. So I know she'll share some very useful information with all of you.
Thank you so much, Avril, and it's a real pleasure to be here, and thank you for inviting me to speak. Kelsey and Olivia gave a really good introduction to why nutrition is important in NETs, and I can see you're already very interested in a lot of diet questions, as a lot of people are. So hopefully I'll be able to answer some of those. A lot of the talk's really practical, so talking through a lot of things that need to be considered when you've got a NET, where the research is at, so a bit more detail about what we actually know from studies that have been done, and then I'll talk a bit about what I'm actually doing to try and increase the amount of evidence we've actually got in nutrition and NETs. So what are really the goals of nutrition in NETs? And some of these are probably common to a lot of cancers, but we want to make sure your nutritional status is the best it can be. So making sure you're a healthy weight, you're not losing weight, also you're not gaining a lot of weight, so making sure that you're feeling well and healthy as best as you can. I think quality of life is one of the biggest things and most important things to people, because what is food? It's not just what makes up our body, it's not just what we require to live. It's a social activity, it's what we do with family, it's what we enjoy, so there's lots of aspects there. Certainly treatment, there's strong evidence for good nutrition in impacting how we recover from treatment and actually respond during treatment. Same with immune function. Symptom management, I think particularly for NETs, symptom management plays a big role in terms of nutrition and diet, and sort of how diet might worsen symptoms in one respect, but also how diet might actually help improve your symptoms, and modifying that might help. I'll talk a bit about what we know about vitamin malabsorption and what you should be looking out for in terms of whether you're at risk or not. And obviously my role as a dietitian in the NET unit at Peter Mac is very much amongst the doctors and the nurses and other staff that work there as well. So I've already mentioned this, but maintain a healthy weight. So if you're not sure already, you can calculate your body mass index by dividing your weight by your height in metres squared. So the healthy ranges, depending on your age, are written there. Don't be too stressed if you're 1 point out of the healthy range. These are really just a bit of a guide. It doesn't really take into account your body composition. So, you know, if you're someone with lots of muscle mass, you're of course going to be heavier than if you're not. Generally, a high protein diet is quite good, so if you're going to be eating more food and needing to eat more, particularly undergoing heavy treatments to maintain your weight, focus on really nice, good quality lean proteins, and making sure you're getting all your amino acids in is important. Eat frequently. This does help control your metabolism, but also make sure you're getting in adequate nutrition and a balanced diet over the day. So try not to skip meals. If you're feeling really unwell and not able to eat, or you are skipping meals, that's when you should mention it to your doctor or dietitian. Australian Guide to Healthy Eating, of which covers New Zealand as well, talks about having a variety of foods. So the more balanced your diet is, the more you've got foods of all different colours and from the different food groups, the better chance you are of getting all your vitamins and minerals and all your major macronutrients as well. In general, for good health, you want to have a diet low in salt, saturated fats, so they're fats that are mostly from animal products, so sort of fat on meat, butter, that sort of thing, and added sugars, so sort of that refined sugar that's not really necessary for our diet. So if you're someone in the room who hasn't got many symptoms and you feel pretty well, these are some general principles to follow and important for everybody. I'm sure treatment's been talked about today, but just touching on all the different treatment types, and each of these actually do have side effects that will relate to nutrition that are potentially a risk. And some might be short term. You might feel sick for a few days after having a certain treatment, or you might actually have more longer term or malabsorptive side effects as a relation to these. So through some of the research I've done, this table really describes some of the key symptoms depending on the treatment type. that might arise, and these are all nutrition related symptoms. So someone's already mentioned that they've had surgery before, so things like steatorrhea, which I'll talk through a little bit more, but essentially what that is fat malabsorption existing through your bowels, other nutrient malabsorptions, diarrhea, short gut syndrome. These really depend on what part of the bowel's cut out, and talking to a dietitian about that can sort of help tailor a diet to you. There are targeted therapies that can cause generalised side effects like fatigue, diarrhoea, nausea. Somatostatin analogues is a really interesting one. A lot of people are on these. Whilst they can reduce your hormonal function, which can improve symptoms in most cases, some patients actually also find their symptoms can occur in terms that they get abdominal pain, they actually get diarrhoea or worsening diarrhoea at times, and that's because of the impact of these inadvertently on the pancreas, and I'll talk a bit more about that. PRT tends to only have very short-term side effects, maybe a bit of nausea and fatigue immediately after, but otherwise patients feel quite well. And then chemo obviously has quite a few side effects that can occur. And this is really just a list of some of the most significant side effects that I come across in terms of talking to patients and managing them. Some of the probably more rare ones to think about are things like altered blood sugar control, so insulinomas and glucagonomas. Patients that I see, probably particularly with insulinomas, we get a lot of heavy input with them to try and control their blood sugar levels as well. And then vitamin deficiency is one that I think a lot of people want to know about, and I'll talk about some of the stats in relationship to that. So in terms of carcinoid syndrome, so most of you probably know what this is, but it's due to the large production of serotonin from affected cells. So if you've got a serotonin producing net, you're likely to be at risk of this. So the most common symptoms: flushing, diarrhoea, abdominal pain, fatigue, wheezing. Some patients report that diet worsens these symptoms, or they just wonder, does diet make a difference in regards to these? Trigger is often a word that people use. Something's triggered my symptoms, or I feel worse. The other thing about serotonin is it can actually lead to deficiency of B3, which is niacin, which is an essential vitamin in our body. The reason it's at risk of deficiency is because serotonin and niacin are both produced by the amino acid tryptophan. That sort of tends to be converted to those things, and normally about 1% of our body converts to serotonin. Was that a question?
Yes, I have.
Yeah.
It's going to be stupid enough, but because of that, I try and keep out of the sun, because sunlight gives you serotonin. Am I being silly?
That's not a recommendation I would normally tell people, so you may not need to be so worried, but I'm not sure. I'd probably check with your doctor. So essentially, amino acid is an essential, tryptophan is an essential amino acid, so that converts to serotonin and also niacin. So when you have an overproduction of serotonin, there's a lot less being converted to niacin, and that therefore leads to a deficiency in some people, not everybody. What are the trigger foods? I get asked this a lot when I see people. They want a food that makes them feel worse that they can easily cut out. Unfortunately, it's very individual. There's no one food that is bad for you. There's no group of foods that are bad for you. Some people find no foods trigger them. It's very individual. I strongly recommend to everybody to try and do a food and symptom diary. If you're someone who has lots of different symptoms and you're trying to figure out whether it's connected to what you eat or what you drink or when you eat and how much you eat and that sort of thing, write it down. Write it down for a minimum of 2 weeks, because our diet chops and changes every day. Write down your symptoms, write down how bad they are, and then you can actually figure out and test yourself, take that to your dietitian, take that to your doctor, and get them to look through it with you and figure out if there is a trigger for you. Probably what we do know is most commonly triggering people though is meal size. So the bigger you eat and the more you eat, the more likely that you are going to get symptoms. Same with fat content. So people do find that if they have a really fatty meal, and you can eat fat, it's not to say you can't, but if you have a really high fat meal, something really fried and fatty, lots of butter, people find that they actually feel worse. Spiced food's another one, and alcohol. Alcohol in moderation is normally fine, but if you have a lot of it, people normally feel worse. You've probably heard the term amines thrown around. So these are foods that contain amines that are, I would say, anecdotally thought to worsen symptoms. We don't actually have any research looking into amines, and no sort of published evidence on this apart from a survey done by the Carcinoid Cancer Foundation. But essentially these are sort of this I would call a bit of a random list of foods, contain amines. So when you're doing your food and symptom diary, think about if any of those foods actually make you feel worse, and that could be why. But I would suggest not cutting them out unless you're sort of absolutely sure that they're going to cause you symptoms, because you don't want to unnecessarily restrict unless you need to. So in terms of fullness and bloating, because this is quite a common symptom, and that came up in the survey that the girls presented, I mean, some general recommendations, and this is really sort of based off my knowledge in terms of gastrointestinal cancer management, but there are a lot of gas-forming foods that we eat naturally through the diet. If you're someone who's prone to getting bloating and gas, if you eat a lot of these on a regular basis, it's only going to be worse. So things like onion and garlic are pretty much in most foods that we eat. So if you try and cut back on those or have less of them, other things like spicy foods, nuts, cabbage and cauliflower, broccoli, some quite common vegetables, they actually will cause gas naturally, even in somebody who doesn't normally have problems with bloating. So it's good to be aware of those. Fibre can be a little bit of a culprit, and these are particularly sort of very grainy fibres, ones that you can see, so like seeds and skins and that sort of thing. So try and cut back on those if you can. Don't completely cut fibre out, but anything that's very grainy or seed-based, better cut back on that. Fizzy drinks and chewing gum, you gulp in a lot of air when you chew gum, so that's only going to make you more bloated. And fizzy drinks obviously have bubbles in them, so that's probably going to make you feel worse as well. Chewing your food will help as well, and sort of how you do that and sort of eating slowly. Things with bloating though, you know, if you've got this constant bloat and it's causing you a lot of discomfort, I would talk to your doctor about it, just to make sure we don't need to sort of investigate a cause of that otherwise. So food intolerances are probably important to talk about, and I'll talk a little bit about the research I'm doing in terms of what patients report to me, but they're often misdiagnosed, and already Kate mentioned that, you know, a lot of patients are misdiagnosed with irritable bowel syndrome and other conditions, which is very true, and I think often patients assume that they might be intolerant to something because someone told them. Often that's not tolerated, or you had it once and you felt unwell. I would probably suggest not cutting something out unless you absolutely know that it is causing symptoms and it's doing that on a regular basis. Symptoms like diarrhoea, cramping, bloating are the ones that tend to be associated with food intolerances. We don't actually have any evidence at this stage to say people with a NET are usually intolerant to this. There's no food out there, so it's very much a personal basis. If I see someone who's finding foods are not sort of agreeing with them, or they're wanting to know if they're intolerant, I'll do a food and symptom diary with them and we'll investigate all the different causes that might be there. So I do discourage severe restriction. I've seen a lot of people restricting unnecessarily, so try to avoid that. This is the food and symptom diary, which I helped develop for Unicorn Foundation Australia. This is on the Unicorn Foundation Australia website, so please access this because this is a really nice, simple food and symptom diary to use. Diarrhoea, another really common one that people talk about. There's lots of different causes for diarrhoea. So the very first thing, if you have got diarrhoea or if you've got new diarrhoea, you must talk to your doctor about why, or get them to investigate why, because it may not actually be an issue just related to your diet. It could be an infection that you've got or other cause. There's a lot of, you know, hormonal hypersecretion causes in NETs that can make your diarrhoea worse, and different treatments as well. Surgery, somatostatin analogues, that sort of thing. If you eat little and often, that will help. So the more food you put into the body, the more likely it is it's going to gush out if you've got a really intolerant bowel. Again, fibre, so I talked about, so there's really visible seeds and grains and that sort of thing. But still fruits, you know, without the skin, and oats, and healthy foods are still good to eat, so don't avoid all your fibres. But the ones that are really sort of grainy and visible are probably, if you've already got a gut that's sensitive and you've got diarrhoea, they'll probably just pass straight through and make you feel worse. So steatorrhea I mentioned before, that's when you've got to start thinking about what your stools really look like, which for some people isn't that comfortable, but essentially if they're floating, they're foamy, they can't flush, they might still be formed, but they're sort of floating on the bowl, or they're a bit pale, that might actually mean that you're passing fat through your gut that you're not meant to, fat that's normally meant to be absorbed, fat that's normally meant to be helping absorb all your fat-soluble vitamins, and often it can be, It could be caused due to just having a net sometimes, depending on what type you've got. It can be caused because of surgery. It can be caused because of treatment that you're on. So I mentioned SSAs, so the injections a lot of patients are on. They can actually inhibit some of the function of the pancreas and that enzyme release that helps you digest food. So sometimes on SSAs, people say, yeah, I have got a little bit of steatorrhea, which is actually fairly easy to manage. So you don't have to go, oh, I'm not eating any more fat anymore. I would tell people to keep eating fat, keep eating a balanced diet, but just try to get some enzyme replacement therapy. So what your pancreas isn't doing properly, you can actually take through a tablet form. And I'll talk a bit more about dosing and that sort of thing. So lactose intolerance, some people might find if you've got diarrhea, you might be a little bit more intolerant to dairy. I'm bringing that up because that can happen, but not to say that if you've got diarrhea you shouldn't eat milk or dairy, because obviously it's a very important thing for our diet. You might find that probiotics may help. Unless you're on chemotherapy, I'd suggest not taking them. But if you're someone who's otherwise relatively well and have a bit of diarrhea and you check it by your doctor, sometimes those sort of supplements can be helpful. If you've got a lot of diarrhea and a lot of fluid that you're losing through your gut, just be mindful of electrolytes that you might be losing and fluid. So drinking a lot of water or electrolyte solutions is a good idea. So a bit more about steatorrhea and fat malabsorption. So I mentioned that SSA injections can reduce that pancreatic function and inadvertently can actually affect your ability to absorb your fat-soluble vitamins. There are 4 vitamins, A, D, E and K, that actually like to be dissolved in fat rather than water in our body. All the other vitamins are dissolved in water. So if you're not absorbing your fat, you're not absorbing these essential vitamins. And they also have a role in many important functions in the body. Don't avoid fat, because these essential vitamins are in the fat that we eat, so we still need to eat that fat. But what we call PERT, which is the short term for pancreatic enzymes, can help absorption. I won't talk too much about prescription of these, but the doctor will do that for you. As a dietitian, I help a lot with prescription and guiding patients as to whether they should take PERT or if it's something that might help them, and certain prescriptions too. Just eating more of these vitamins and more fat unfortunately won't make a difference, because you've got a problem with the absorption of these things in your diet. So in terms of the amounts that people take, so normally it's something you've got to take as soon as you eat, and it's essentially like a little capsule that you have, so it's sort of like taking your enzymes through the mouth rather than what's being released from the pancreas. So in terms of vitamins, just to summarise some of the key ones that people should be aware of when they've got a NET, and certainly just because you've got a NET doesn't mean you're going to be deficient in vitamins. There's some very specific different kinds that might be. So I've talked about the fat soluble, so if you've had a pancreatic NET, surgical resection of your pancreas, you're on somatostatin analogues, I think particularly if you're on them for quite a long period of time, maybe ask your doctor if you should be concerned about it. You can test these through a blood test, although not routinely done. Vitamin D is very routine to be tested, and the treatment, like I said, is PERT. B12, so for people that don't eat a lot of meat, so B12 is commonly contained in meat, or if you've had stomach and bowel surgery where most of the B12 is absorbed or assisted to be absorbed, that might mean you're at greater risk of that deficiency. Very easy blood test, only takes a day or two to come back to test if you are deficient. If you are, you usually get anemia, and it's treated really easily through an injection or oral supplement which your doctor will prescribe. Niacin I've talked about, so the reasons why niacin can be low. So if you're someone who's known to have a serotonin producing NET, or if you've got severe carcinoid syndrome, I would talk to your doctor or dietitian about, should I be taking a supplement? Should I be taking a B supplement? Or should I actually get a test? Mind you, I'm fairly sure New Zealand don't have a testing facility for niacin. Australia has one centre in New South Wales that will do a urine analysis for niacin status. So not all is lost. Often it's appropriate to say to someone, take a supplement in case you're deficient, because it's not too many side effects of taking a B3 supplement. Carcinoid Cancer Foundation suggests about 25 to 50 milligrams twice a day, but any supplements you do want to take or think about, just mention it to your doctor. And I just mentioned iron as well, so again, if you don't eat a lot of meat, I find a lot of patients go off red meat, particularly when they're feeling unwell, or if you've had bowel surgery or any significant blood loss, it might be at risk of iron deficiency and might need to take a tablet. So a bit about what the evidence says, because I find a lot of patients like to know what does actually the research say about vitamin deficiency, how many people are affected. I've talked about the risks in terms of these fat-soluble vitamins, but in the research, a couple of key studies have been done, and actually higher numbers than you'd expect. And these were looking at patients who were on long-term SSA, so patients on a year up to 18 months or longer. For some vitamins, up to 80% were deficient. Didn't feel any different, but upon a blood test, had an underlying deficiency. So I'm not telling you that to freak you out, because these are only very small studies, so it's not to say that a lot of people will have these deficiencies, but it's just to flag that you don't always get symptoms if you have these sort of things. Sometimes it's just good to get a blood test and to check. So with niacin, what proportion? So only 2 studies most recently have really looked at prevalence of these deficiencies. So in patients with serotonin-producing NETs, so known NETs like that, or carcinoid syndrome, sort of 28 to 45% had, again, a biochemical deficiency, so didn't feel any different, but upon testing was shown to have a deficiency that was easily treated through supplementation. But the prevalence of actual clinical signs of niacin deficiency, which is pellagra, so sort of skin changes, confusion, that sort of thing, is very, very small. In Australia, I find a lot of patients are interested in the microbiome. There seems to be a lot of chatter about it, so I just thought I'd mention it. What is it? Essentially, it's all the microorganisms in your gut. If you're someone with diarrhoea, you might have thought about this a little bit more. So normally these organisms, they help sort of break down food in your gut, they help your immune function, they sort of prevent all the bad bacteria and infections getting in. Sometimes you get an overgrowth of the bad bacteria, or a sort of change in the diversity of your gut microbiome. And there has been a bit of research sort of emerging in terms of what connection there is between your microbiome and your gut, and whether certain treatments are differed in terms of how you respond to them and that sort of thing, in terms of how you feel and your symptoms if you change your microbiome. I don't have any solid answers in terms of that, but just to be aware that people are saying it sort of does matter in terms of the diversity of your gut microbiome, and it can improve your immune system and immune response if you've got a good one. I was chatting to our gastroenterologist at Peter Mac recently about this, and if you see a gastroenterologist, you can get your microbiome checked. I'm not sure how involved it is or how much it costs, but if you're someone who's interested or worried about it, definitely talk to an expert. Prebiotics are substances that contain sort of fibre inulin that can actually sort of help our gut thrive. So they're not bacteria themselves, but it's sort of foods in our diet that can actually help. So if you can tolerate these foods, mind you, some of them I've mentioned, like onion and garlic. If you're someone who's bloated and intolerant, don't increase those, but sometimes they can be helpful. Probiotics, which are more coming in the yogurt, the tablets and other forms, actually contain good bacteria like lactobacillus, bifidus, those sorts of things. It can sometimes be beneficial if you've got a bit of IBS or diarrhoea. Also may be beneficial in combination, but to emphasise, it's a really emerging research area and we don't really have any definitive answers at the moment. So that's a snapshot of where we're at in terms of nutrition and NETs, in terms of how we're managing it now. I'm just going to give you a little snapshot of what my PhD is. So I'm actually analysing data at the moment, so I don't have any key results to talk to you about, but I'm hoping by January, February I will. So the aim of this is really because we don't have any comprehensive description of nutrition issues that occur in NET patients. We've got a wonderful survey that's been done in New Zealand, but in Australia we've got no data on what are the complications that occur, what proportions of patients get these complications. So this is really a study that's looking at all of those, and hopefully will give us evidence to sort of inform future screening programs, increase input from dietitians in the area. So patients were recruited from 2 centres in Melbourne, including Peter Mac. So when they were referred to Peter Mac, they were put on the study and then they're followed for 6 months. So we watch any issues that happen over 6 months. Second phase of my research is actually looking at the health professional side. So we did an international survey of health professionals, experts in NETs around the world, and got them to fill in questions about how they manage nutrition, what they think is important, what patients have reported to them, to get a bit of a snapshot about what's happening in the world in terms of practices amongst clinicians. And that's not just dietitians, it's actually doctors, nurses and others. And we did focus groups with clinicians more locally at the NET Centre in Peter Mac. very busy slide, but I just wanted to highlight what we are collecting from patients from that initial phase. So we're looking at their quality of life, which obviously underpins, why all this is important. We are looking at vitamin status, so all those vitamins I mentioned to you, we are asking patients if they're willing to get measured in those, and we will have that prevalence data available by the end of the study. We're looking at what symptoms they get, and this is sort of every 2 months over 6 months, what medications they're taking, including supplements, whether they're malnourished or not, and any weight change that happens over time, because we don't really have any data worldwide about weight change in NETs, either way, weight loss or weight gain. Whether they see a dietitian, and dietary habits, so a lot of detail about have they changed their diet, why, who initiated that, and also we're doing patient interviews to get more in-depth information about that too. So recruitment's finished, and we're still following up patients over time. So quite a range in the different types of NETs that were recruited. And a lot of patients actually, especially when they're referred to Peter Mac, had some treatment elsewhere, so maybe in a smaller centre that wasn't a NET specialist centre. So a lot had already had treatment prior, which obviously would impact the symptoms they get and in terms of some of the other outcomes we might find. So a little bit lower to what the girls reported in their survey, but at time of recruitment, so this may change over the 6 months and we haven't got that data just yet, but over half had changed their diet. And these are people that have changed their diet because of symptoms or because of what they believe to be an intolerance or sort of not managing food. I've listed there the most common: alcohol, red meat, dairy, spicy or fatty food, and heavily patient initiated. So very few patients had even asked a doctor, a dietitian or any health professional about whether they should or not. They just decided to do it themselves. Over 75% were eating smaller meals or less than they would normally. And out of the interviews, we noticed obviously a lack of NET-specific guidelines, and patients are really seeking information about diet. And I think not necessarily asking for it from their doctor, they're sort of looking for the sources around the place. But most are actually keen to talk to a dietitian even generally about diet. And the impact of diet on social activities is quite pronounced as well. I haven't got results for phase 2 to talk about, but just to show that we've got over 70 health professionals from around the world that have completed our survey. And then focus groups got 13 from Peter Mac as well, and quite a nice little mix of countries there. So feel free to email me if you have any questions that you want to ask me, or sort of ask any questions about how to access an appropriate dietitian if you want to see someone. And our Nutrition and NET booklet that the Unicorn Foundation Australia has developed is the best resource we've got at the moment until the toolkit's available, and a few other resources there as well, but happy to take any questions.